Ladies, distinguished ladies and gentlemen, it is my great honor and privilege to provide some introductory remarks as chair of this session. I'd like to seize this opportunity to thank the organizers most heartily for inviting me to chair this session. And I must remark that I've learned a lot since I came here yesterday, and so have many people. And it has been a very, very impressive organization that will remain indelible in the minds of many of us for quite some time. Now, the aim of this session is to discuss the Ethiopian national perspectives that weigh on the benefits and costs of financial and human capital investments in young children and their caregivers. Among the problems confronting early childhood development generally in African countries south of the Sahara, the following call for very close attention. 1. Diseases such as malaria, measles, tuberculosis, tetanus, Ebola, polio, yellow fever, and so on. I'm not saying all these are in Ethiopia, but these are common problems for many countries south of the Sahara. Then the second problem is malnutrition and poverty generally, Then the third problem has to do with early childhood education. And this has many facets and ramifications, including suitable curriculum, adequately trained CDE teachers, and so on. And then the fourth aspect has to do with acute poverty, especially among the disadvantaged children. And also, how do we study these things? So the role of research will also be very important. Now, for effective solutions, it will have to be all hands on deck for parents, family, community, local government, state governments, national government, and global community. Now, I'm not saying it has to be in that order. It is in a rather intertwined order. You cannot say this one comes before this, or this one comes before that, and so on. The whole thing is interwoven. In order to prepare young children cognitively, physically, socially, and emotionally for future success. This calls for a lot of investments with consequent returns of needless. In fact, some of the consequences are very far-reaching, among which are needless public spending in various unproductive directions, including even criminal justice systems for juveniles and adults. Because when you don't bring your child up well, it grows up to be, a burden on the society. And this we are avoiding by all of us gathering here to talk about a very good ECD. And adults who, while also lowering school dropouts, when we train our young children well or bring out them well, they don't end up as dropouts, and ensuring skilled and responsible workforce that contributes to the revenue, that's it, tax base. If you want citizens who will pay taxes in future and increase revenue, you have to bring them up very well from the beginning. Even though we shall hear from our Ethiopian colleagues during this session about national policy perspectives in Ethiopia, it is noteworthy that quite a number of African countries south of the Sahara do have policies based on some intersectorial collaboration between various sectors of the society, which, among other advantages, make for cutting costs through sharing of resources and avoiding duplication. There are many advantages we get with this multi-sectorial approach. And as I've said, some of them has to do with cutting down costs and avoiding duplication and making the best use of available resources, both human, financial, and others. However, the most comprehensive is that of Kenya, which I tried to mention yesterday, that has a policy based on collaboration between at least 10 sectors, namely parents and other caregivers, community, ministries of education, health, home affairs, finance, local government, agriculture, culture, sports and social welfare, faith-based organizations, bilateral and multilateral development, and so on. It is hoped that other African countries will emulate the example of Kenya in formulating policies that will spell out the various sectors involved. The thing is, we should congratulate them for writing things out, and it's very comprehensive because it says at what stage what each sector is going to contribute. Granted that they are not yet implementing well, of course, for many reasons that happens in developing countries. But it's good that at least once you have something on paper that one can fall back on for further development and also make a good example for other countries. Now, just my own small suggestion at the end of this session, since we are going to have some of the speakers from the government of Ethiopia, and this is the seat of African Union in Africa, I propose that we make the following recommendations to the African Union through the Ethiopian government, who are represented here. One, that all African governments should have viable and comprehensive ECD policies. It's not every country that has, and with many of them, the policies they have are rather fragmented and so on. And as a scientist and the president of African Academy of Science, this is something I like to propagate everywhere I talk because it has also to do with bringing up our children well. That all African governments should create science centers, one in each province of their country, where children could have hands-on experience with basic scientific facts, e.g., how the telephone works, what causes rain and thunder, because there's superstition all over the continent that maybe you can kill somebody by sending thunder to him and so on. But if our children learn to play around with these things, it will be good, and also perform their own experiments. So these are some of the ideas I have that can serve as prelude to what we want to do here. Without wasting time, I would like to introduce Professor Elia Molina, the Vice Dean of Research and Development, Faculty of Medical Sciences, University of Santiago de Chile, and a former Minister of Health in Chile, Professor Molina. Thank you.
To present Mr. Yasabu Birknen, sorry with the pronunciation, you know, it's very difficult, the pronounce, Director of a School Improvement Program, Directorate, oh, in the Ministry of Education. Dr. Ephraim Tekel is coming. Huh? Mr. Yayes Tesfahune, Director of Child Rights and Promotion Directorate, Ministry of Women, Children and Youth in Ethiopia. The reaction of the presentation is going to be in charge of Yaye Jira Kitao, Independent Consultant, Ethiopia. We are going to begin with Mr. Birken. She's going to present the policy and implementation in Ethiopia of early child care and development in education. Do you want to present from here or there?
Okay, I can.
There is better. Thank you.
Okay. Dear coordinators of this forum and participants, first of all, I would like to express my pleasure to speak in the front of this big forum. Thank you very much for giving me this chance. As it is, communicated by the coordinators, my presentation focuses on, or my short speech focuses on what the Ethiopian early child care and education policy looks like, and what is the implementation looks after, based on the policy framework in the country. As a general background, I wanted to say something about the importance of this investing on early childhood care and education. And please allow me to say ECCE to mean early child care and education. Can we communicate on that? Okay. Generally supporting young children and families is an investment by itself, which the return will come later. This is to mean increasingly research has demonstrated that investing high quality of services for younger children, their parents, produce significantly returns. What returns? The early drop out of children in the formal primary school will decrease if we are investing on ACCA. The achievement of children significantly will be improved if we are investing in ACCA, and their emotional psychological development will be also maintained well if you are doing such provision in the early age of children. So, adopting a well-designed package of investment in children from birth to 5 will improve children's health, school achievement, opportunities for future economic success, and this will be good for the country as a whole, as for the children. These are, in short, the importances that we obtain as a result of investing in ACCE. And most of the child's development, the fastest rates of the child's development will take place in this age. So the latter age will be a matter of coordination, connection. So having or giving great attention in the early age of children will contribute to the latter normal development processes and the elements that I have mentioned before. So, in general, investing resources in supporting high-quality early child education experiences for children will definitely provide the building blocks through providing early stimulation and quality care, and it is a building block for future success in school and the task force and the society. These are the importances. The Ethiopian government, therefore, understands these facts very well, and based on these general facts and principles, the government committed itself to develop a policy framework on ACC, child care and education. So one of the important steps taken by the government regarding ECC is the formulation of the policy, without which any intervention may not be easy. So we have formulated, the government formulated the ECC policy, and the policy framework. What is the importance of having this policy, or what is the role of this policy, is provides a coordination mechanism and explicitly defined the roles of the partners, the parents, the communities, and the various sectors. It explicitly defined the roles and responsibilities of actors in ECC. Again, based on the general policy framework, which explicitly defines the roles and the responsibilities of actors, the government has also developed a strategic operational plan and the guidelines. And what is this meant for? It provides, it helps us to put action the general framework. It helps the general framework into action. So, the policy documents have formulated and get approval, and different steering committees are organized, and they signed MOU, Memorandum of Understanding. This memorandum of, they have taken, these different stake committees have taken their responsibilities and signed a Memorandum of Understanding. In general, the documents that I have said before, this is the general framework, policy framework, and this is operational strategy plan and guideline regarding the ECC. So, what is the role of this? At the bottom, these are the ministries who signed a memorandum of understanding by taking their specific role. What are these specific roles? Ministry of Health. Ministry of Health will have the lead for the young children from prenatal period to the 3 years age group. So all the services delivered at this stage belongs to all, the lead responsibility of the Ministry of Health. Again, the other actor is the Ministry of Education. Therefore, the ministry is responsible for age 4 to 6. This is where the ACC, an actual intervention in ACC is made. So these are the actors. What are the modalities for ACC program in Ethiopia? We have the normal kindergarten. This takes from 4 years to 6 years. And this is the normal program, the formal program. But it is difficult for the country like Ethiopia to address the issue of ACC only by this intervention. Therefore, we have another modalities, and this like the informal modality. This is child to child, when the elder child used as a facilitator and used very flexible venues at their home, and the elder facilitator, grade 5, 6 students will help to facilitate the on game basis for the younger children. So it may be, the shadows that is at home, or the home of any, one of the home of the villages. So this is the services. So children will get a preparatory services for the formal education. And by the way, it contributes a lot to the preparedness for formal school, and its impact is studied using the fund obtained from UNICEF, and the Toronto University of Canada made impact study, and it listed the various importances that are obtained as a result of investing as a result of implementing this child-to-child school readiness program. And the other is all classes, where the 6 years children will be given the service for 1 year of simulation and readiness program. And for this purpose, schools, the formal primary schools are attached to one center in the school where this 1 year school readiness program service will be delivered. So it's bigger some years, 3 years or 4 years before, but now almost every schools in the country have, have the responsibility or receive the responsibility to deliver these all classes. So, as a result of which, the percentage of achievement, what are the achievements? You see, in the period of the, as the baseline of the growth, the GDP, we had 4.6, I will stop soon, 4.6%. But now we are able to 34.7, means the coverage, the access of ACC in the country becomes 34.7. This is a great achievement, but it should be noted that still we have children, we are not able to get this access. We do have the challenges, many challenges. I will not list them, but the major ones is the quality of the service, the facilities, and the awareness of the parents. These are some of these challenges. And I do have many pointers to say, but time comes against me. Thank you.
Well, Mrs. Yayes is going to talk us about the...
Before you start, I would like to invite Dr. Kabede Worku, who's the State Minister in the State Ministry of Health, who just arrived, and I'd like to invite you to join the panel. Thank you.
I couldn't hear. What she said? It's not coming?
Thank you, Professor Adormi, and thank you, Professor Helena, for giving me this opportunity. My topic is how community initiative is investing on children. As my colleague was explaining, in Ethiopia, we have a policy and legal frameworks which enable the people to participate in investing for children. Our Ethiopian Federal Democratic Republic Constitution, our family law, our penal and civil law, which is in line with the International UN Child Rights Convention, African Child Rights Charter, are a very good milestones for us to work for children. We have also policies like social protection policy, comprehensive national child policy, social protection strategies, and our growth transformational plan is also enable us to invest for children. Accordingly, in Ethiopia, tremendous results are achieved in education, in health, in reducing harmful traditional practices, and poverty reductions. However, there are also still children in need of care. There are children without adequate care, and there are children without parental care as well. So according to the International Convention of Child Rights, we have different alternative care mechanisms put in place to give a care and support for those children. So, in line with this one, we have productive safety net programs, we have food securities for families to strengthen their incomes. But, as I explained, there are still leftover children that needs community's help. So our main focus in Ethiopia is how the community by themselves to contribute and to give solutions for the children. So we have a good kind of community-based care. which is an initiative come up from the community at a grassroots level, which is the smallest unit of our structure. We call it Qabale level. People came together, they identify who are vulnerable at that community level, and they put plan with some priorities, and they mobilize resources for those children, and they take care of them. The contribution could be time, it could be also cereals, it could be also money, it could be also different kind of follow-up mechanisms for children to be protected from different kind of vulnerability. So accordingly, I would like to show you a video so that it will explain what I am saying.
Ethiopia, the ninth largest country in Africa, has a population projected at 82.5 million. With one of the fastest growing economies, the children's population comprises around 55.5%. Those children without parental and adequate care have a right to alternative care, and the state has responsibility to provide care. Recently, Ethiopian Ministry of Women, Children and Youth Affairs is working to reduce inter-country adoption and to encourage other childcare options which directly involve the society which embraces the children.
Our society and community should be able to help children who are in need. We must love, care, and help them in any way we can. Children are the ones who will hold the future of our country, so each one of us has the responsibility of leading them in the right direction.
Jeremiah lives with his grandmother because his parents have passed away. He lost both of his sight when he was 10 years old. The responsibility of raising Jeremiah and his brother laid on their 80-year-old grandmother. Ethiopia, the ninth largest country in Africa, has a population projected at 82.5 million. With one of the fastest growing economies, the children's population
And it comprises religious persons, children, teachers, and community leaders which are dominant at that community level. So they contribute what they have, and they have their own plan, and they identify the vulnerable children, and they give priorities, and they give the care and support materials, cereals, times, or it could be also maintenance of their houses. They have their council at the community level. They report to the council, and they have also a committee which is composed to mobilize the resources. So they deliver the report to the council, and every day, every time, they watch how they can get resources from the community, and they are taking care of children. So by now, we have 3,700 community care coalition in 7 regions. So our ministry is trying to scale up these kind of initiatives. so that for children to get sustainable caring solutions from the community. So thank you. This is the one that I would like to entertain for today.
Okay, thank you. Now I have the honor to present Dr. Kebede Worku, State Minister at the Ministry of Health. He's going to focus his presentation in maternal and child health.
Thank you, Madam Chair. Dear Professor Damse Habte, President of Ethiopian Academy of Sciences, distinguished guests, dear organizers, ladies and gentlemen, I would like to thank the Institute of Medicine of the U.S. National Academy of Sciences and the Ethiopian Academy of Sciences for organizing this important forum on investing in young children. In day-to-day life here in Ethiopia, we value human health very much, and there are many local proverbs and sayings related to health. Among these is ጤናችን ሀብታችን ነው. Our health is our wealth. I want to point out some important articles of the Constitution of the Federal Democratic Republic of Ethiopia related to health of women and the children and the general public. We have Article 35, which dictates about rights of women. There are some sub-articles related to the influences of harmful customs, which are prohibited, including laws, customs, practices that oppress or cause bodily or mental harm to women are also prohibited. Right to maternity leave, to ensure health of mother and the well-being of a child and the family, and the prenatal leave as part of the maternity leave, and the right to access to family planning, education, information, and the capacity. Article 36 dictates on the rights of children to life, and also to prevent them from harmful practices. Article 41 states about equal access to publicly funded social services, including health. Article 41, sub-article 4, is about governments to increase resources to public health, education, and other social services. Based on this, the government has given priority to maternal, newborn, and child health services, and has been implementing different sectoral strategies to improve maternal health, reducing maternal mortality, improve child health, and reducing child mortality in the nutrition services. Maternal, newborn, and child health services are provided in integrated delivery mechanism at all levels, including at community level. The government has invested aggressively in expansion of primary health care infrastructures and the training and deployment of human resources for health. We have homegrown community health services, which we call it health extension program. It is institutionalized community health service that focuses at household in the community. Basic philosophy of the health extension program is to facilitate transfer of knowledge and skill from health extension workers to individuals, particularly mothers, households in the community. As health extension program is focusing at household, the key players are mothers who are also caregivers for children and the family members. Women and the children constitute more than 70% of the total population. Integrated services are provided by the health extension workers at community level. These are maternal and child health, family planning, immunization, adolescent reproductive health services, nutrition, hygiene and environmental health, and prevention and control of communicable diseases. Communities are also important players, and the health extension workers mobilize communities and enhancing demand creation and utilization of services. We call such organized community movement health development army. Households are networked and the moderate households are providing support to their fellow neighbors to scale up best community practices. We have developed reproductive strategy and adolescent reproductive health strategy in the MCH roadmap and implemented at all levels of healthcare tiers with community mobilization and participation. The Health Development Army has helped in significantly improving service uptakes. For example, one can witness how systemic mobilization from national to local levels have improved skilled birth attendants in health facilities by addressing critical bottlenecks like attitudinal, infrastructural, supplies, and institutional capacities. Improved maternal care means improved newborn and child care. Health and the well-being of caregivers have significant impacts on child health and nutrition, both positively and negatively. If the mother is healthy, she can care for her kids, but if her health is affected, she can't care for her kids. Very cheap but sensitive tool, which we call visual inspection with acetic acid, VI, seeing the treat, with using cryotherapy. We're also going to introduce human papilloma virus vaccine, and that will be also part of improving maternal health. We have a national nutrition strategy in the program that was developed and then being implemented, integrated into health and other sectors. Investment in nutrition services are worth investing, as adequate nutrition means assuring national human capital development. It is worth mentioning the cost of hunger in Ethiopia study that indicated significance of nutrition in different sectors like health, education, and productivity, and the annual costs associated with undernutrition, child undernutrition, was equivalent to 16.5% of the national GDP, as indicated in the study in 2009. Malnutrition in adolescent girls and the pregnant women leads to intergenerational cycle of nutritional problems. And the first 1,000 days of life of child's health, from pregnancy to 24 months of life, are window of opportunities for health and development. As one of the health exchange package, nutrition services is also provided integrated at community level, where like nutrition education on early initiation of breastfeeding, exclusive breastfeeding for 6 months, and appropriate complementary feeding and extended breastfeeding beyond, including growth monitoring, the promotion, early detection, and the treatment of severe and moderate acute malnutrition, and supplementation of vitamin A, and the use of iodized salts and other micronutrients. I think Wezoyesha has mentioned about early childhood care and education, which the three ministries, Minister of Women, Children and Youth Affairs, the Minister of Education, and the Minister of Health have signed commitments, a memorandum of understanding in 2010 to institutionalize, to enhance preschool stimulation and care, as well as community-based services, including school readiness at community level. One of the investments that we call for what we apply for kids is expanded program on immunization. One of the high impact, cost effective preventive services that is also integrated into our community health services. Vaccination program gives opportunity to children and mothers immunity for vaccine preventable diseases like tetanus, measles, and the poliomyelitis. The global community has targeted eradication of polio using vaccine as weapon, and a lot has been achieved so far in the battle against circulation of wild polio virus in the last 2 decades. We are decentralizing low-cost, high-impact intervention to community level, like community-based newborn care and integrated community case management of common childhood illnesses provided by the health extension workers. And to understand, health extension workers are community health workers, but they are government employees. They are formally trained, but deployed at the community level. 2 weeks ago, I visited one of the health posts around 75 kilometers south of Addis, and I have asked the health extension workers whether they are applying these services. They told me that they have treated 12 newborns and 72 under 5 children in the last Ethiopian physically, and they have saved their lives. So imagine what does it mean having such services at community level, access to the family at community level. We are also applying malaria prevention and control interventions and a series of malaria strategies have been implemented, and we are targeting mothers and children, and we have dramatically reduced admission and illness from malaria. HIV services are also provided integrated in services, and since the launch of the free ART services, mothers and children are also getting access. Otherwise, prior to the free ART supply, the services are not accessible to the mothers. I don't need to mention the issues related to harmful traditional practices, to particularly that are affecting health of mother and children, as the right ministry is with us, related to early marriage, teenage pregnancy, and associated abuses like sexual abuses, both to the mothers and the kids, women and kids. The gains in the success registered are the result of political commitment, community participation, and effective partnership. Though we have achieved MDG 4 and on track to achieve MDG 5, still there are many children and mothers who are dying from easily preventable diseases. The government and the international community need to scale up implementation of effective interventions by increasing high-quality investment on children and the women's health to harness maximum benefits. Thank you very much.
Now you have the power to do what you were saying for a long time. This is very, very interesting. And then now go ahead and do, and you have to, what is necessary to do, and you have to do, and always you must be coherent with your biography, but it's not so easy. Another thing is with guitar. Who have been spent years in the field of research, advocacy, activism, repeating over and over what is need to do in terms of early child development, for example, is the key issue in this forum and event. We know what is necessary to do. We have all the knowledge. We have the evidence. We have the human resources, but now we know what works, what doesn't work, how much cost, which is the rate of return of the investment. And now we have the strong evidence about the role of pregnancy, for example, during the period of the first years and the first years of life as a window of opportunity, unique because the critical period of the brain development, as well as the cost effectiveness of the intervention. We know a lot. We know a lot. We need to know more, but we know a lot. But what happened when we are in the policymaker position? What happened in that moment? Now you have the guitar in your hands and you have to play the guitar. It's a big challenge. Political will is crucial, but political will alone is not enough. We need to have, in Chile we say, political will truly love. That means political will with money, with a budget, with the support, in terms of political support, in terms of governance support. As Ministry of Health, I had the opportunity to understand the complex context, not only in terms of the technical approach or the technical way of to prioritize the different programs to implement, but you have to deal with the complex world of the politician. They are demand for many group of interested, a lot of persons, and when you have to be very convince, you have to convince, you have to be very clear to show all the arguments. But in terms of early child development, it's not easy. Why? Because the children don't vote. First issue. It's not interesting as a target for politicians. And on the other hand, the strategies in early child development give the fruit, or we can have the impact measurement, not always in the same time with the politician need to have results. It's easy for a politician or for a president to build a hospital or a school than to implement integrated policies with an intersectoral approach, with a lot of period to monitor the result, the process, and the outcomes are always far from the timing of the politician. I think that when you have the opportunity to do the things, to put in action all the knowledge, and to have the opportunity to really mobilize resources for this objective, I think that is a real challenge. The presentators show what they are doing, but maybe it's interesting in each country is different. But for me, it was not so difficult because the president is a pediatrician, is absolutely convinced of the importance of to promote early child development. Then for me, it was easy in some terms, but not easy in others, because most of the people in general is more close in terms of the Ministry of Health to ask for attention for disease. They don't want to promote anything. They want to receive attention, and this is the real challenge: how to put this early child development as a key issue, not only in the political agenda but also in the community. And I think that it's only a few words to give a space for the discussion. Please, who want to ask to our presentators? No? Nobody? Ah, there. Please.
I'm Makonnen from Save the Children. My question is toward the Minister of Education, the first presenter. As we know, ECD Center or O-Class is based, it is school-based. But there are other children far from the school. What other strategy to address the children far from the school? What is the strategy of the ministry to reach those children?
Thank you. We are going to hear some, and then you can answer. Here.
Hello, thank you for coming. We're so pleased to have you here. I'm Ann Maston. I'm a professor at the University of Minnesota in the United States, and I co-chair this forum. And my question, and it's a very important one, I think, to hear your voices on. We know that the science is growing stronger every day for the importance of investing in early childhood, that it has many long-term returns for the child and for the society. And the question I have is, how can scientists help ministers make those good arguments for investing in early childhood? We see, you've talked about the challenge, and we understand it can be very challenging. How can scientists help with this issue?
Thank you. Thank you. There.
Thank you. My name is Desalin Shanko. I am from the Save the Children, responsible for education in emergencies. My question goes to Ministry of Health, to Dr. Kabada first, and again to the other Dr. Ephraim. First of all, I would like to commend the endeavor of Ministry of Health programs of Ethiopia. It is also commended globally. So thank you for the presentation too. What mechanisms are there to enhance the health aspect in the community? What community support programs are there? You told us what the ministry is doing, but what things are there? For example, if I take the Ministry of Women and Children Affairs, they do have robust community programs, and by the same analogy, do you have something, it is related to what the chair has explained at last. The other is regarding the non-formal programs of ECCE to Dr. Ephraim. I wish the Ministry of Education was there here, but they are not there. Oh, sorry. Are you from the Ministry of Education?
Sorry?
Okay. So my question is regarding the non-formal setting of ECD education. The non-formal is globally is not well exploited portion of education. I am glad that non-formal education is contributing to ECD. But you presented the achievements from 4% to 34%. I'm asking, how about the quality aspect regarding this non-formal? The non-formal setting has to be well organized in terms of quality to achieve its results.
Thank you. Thank you.
Yeah.
These are, okay. Another question?
Thank you. My question is directed to Dr. Ephraim from the Ministry of Health. I want to know as to what is the rate of infant mortality in Ethiopia, because we are talking about children thriving, but before they thrive, they have to stay alive. So are they dying? Are they staying alive today more than they were alive 10 years ago or maybe some time ago? And I'd like to know from both ministries as to how do you make sure that you work together? Because what we are seeing in our countries is the Minister of Health pulling another direction, the Minister of Education pulling another direction. So how do you make sure that you work together as the two ministries on issues of early childhood development?
Thank you. Well, someone need, no?
So can I ask
You?
to elaborate on the last question? It just occurs to me that while the Honorable Minister is trying to answer the last question, there are several issues I raised in my introduction about what is, we have ideas about what happens in other countries, about actual national policy that integrates a lot of these approaches through many sectors. Beyond Ministry of Health and Education, I will appreciate some information for the benefit of all of us
what national policy exists in Ethiopia that will accelerate progress on early childhood development.
Thank you. Well, the questions are very clear for each of the presenters, but one question is common for the three, because it's the need, which is what you expect from the academy. Then we can begin with you.
So if I begin with the all classes, I think the question is, other than the all classes, what are the other modalities to address or to increase the access of ACC program? I mentioned, of course, in my presentation, though it was in a very speed manner due to time, but I raised this child-to-child issue. This is one formal program where the elder child with some orientation are given this responsibility based on what? It is not a very academic issue, but based on a play context, they are playing the role of facilitator for the younger children. So this is one form of non-formal. And the other is that we are very recently piloting is the accelerated school readiness program. Means children who are not able to have these different services so far will get this accelerated child readiness program for 2 months in summer in their home, and the teachers will be assigned with some orientation and training, and they will help as their home. They may not need to go to school, and the distance issue will not be a problem because the service will be delivered at the house level, and this is targeted to reach children who are not able to get the other the services through other modalities. So it is piloted and in the Benishangul regions, and based on the findings or based on the results, we will roll out to the other regions like what we have done for the child-to-child readiness program. You see, the same is true for the child readiness program, child-to-child school readiness program. We piloted in some regions, and based on the impact is studied by independent body, and we do have the findings, we give the findings. Based on that, you see, we rolled out to the other regions. So we are trying to, deliver the services using, different modalities. Regarding, what is the role of the scientists, we do have, different professional associations, and we do have also universities. By the way, one of, the actor, one of the actor for this ACC coordinating stakeholders is the academia, the universities. By the way, even the very essence of before the launching of this policy documents, a study has been conducted by the university people, and it is based on the findings and of bringing the national and international experiences, and they are convincing the government and come up with this policy and operational strategies. Therefore, we are working closely with the university, especially Addis Ababa University is playing a leading role, and we are working together, and they are making different studies, which the results are important inputs for the decision makers. And we have also another professional associations like the Young Lives. They are studying the longitudinal development of the education services at youngest life. Therefore, we are taking they presented their results at the different forum, which help us to make input, to take as input for further development. This is one form. And the other is the quality issue for the non-formal, yes, but it is not a mere problem for the normal mode of delivery. We do have these challenges even on the formal approaches. The university level, by the way, quality is also a relative issue. We are trying our best, to address the issue of quality. Like by what? By improving, the facilities as far as we can, because it is also dependent on the capacity, and we are also training facilitators, teachers. So and we are the different making studies and researches are also important interventions to make all the necessary qualities. Therefore, yes, quality is an issue, and we are working also to address these quality issues using the interventions that what I have tried to list. And I think these are the issues. They are closely working in conducting, different researches and studies, which are important input for policymakers. As I mentioned, as an example, even the policy based on, the study, which is done by, the prominent university, the Addis Ababa University, and we do have, many interventions and trainings done by, the university.
Thank you. Now I'm going to give the word to Mrs. Yayes. Okay.
What I would like to intervene is how we can coordinate the Ministry of Education, Ministry of Health, and Women's Affairs in regard of early childhood education. Our main responsibility to make in effect this policy and strategies to create awareness to our community. We have different kind of community awareness programs through TV, through radio, press, and face-to-face community mobilization as well. We have also a good community structure, what we call Women Development Army at the community level. This Women Development Army is composed of 25 to 30 women at their neighborhood, and their main purpose why they come together is to take care of whether their children are going to school. So there is a follow-up responsibility for the mothers. So our main responsibility is to make aware this Women Development Army so that they have to take care whether their children are getting vaccination, mothers to go to the health centers for delivery, and to take care of for children to go to school, including early childhood education, that is the O class and all the things. On the other hand, the responsibility of the scientists at the university is they do different researches on about early childhood issues, on about vulnerability of children, because one of the responsibility of the university is community responsibility. They have to work relevant researches based on the context of their community. So their contribution is they do researches, they do trainings, and they collaborate with the community in this regard. So thank you.
Thank you. Now I'm going to give the voice to Dr. Kebede.
Thank you. You have pronounced it well. Huh? Access to education is not a problem these days in terms of physical infrastructure. The net enrollment is more than 92% for primary school, and the gross enrollment is even more than 100%. So physical access to schools is not an issue in Ethiopian context, except in remote pastoralist areas, which we need to enhance. So, I don't think it will be a problem, but our system is based on the informal setting, using this strategic framework and policy, which the three ministries have signed: Minister of Education, Minister of Women Affairs, then now it is inclusive of children as well as youth, and the Minister of Health. So we have developed policy based on studies and also pilots in collaboration with UNICEF education section, and with the pilots as the older child helps his siblings, younger ones, in alphabet and numeric teachings. At the same time, parental education is a more important one. I think there is no better school ever than our families. And so the schools that we are going into are to provide us another style of education, a style of development. So we are basing ourselves on parental education and also informal preschool readiness on top of the formal school readiness. And the government is now bold enough to increase the uptake to preschool to around 80% at the end of the next 5 years. So the government is committed in incorporating into the formal education system of the O class or 0 class. So that need to be understood. And we will not expect nurseries in our remote communities. Our mothers are staying at home, caring for their kids, and they don't have other livelihood engagements, or they don't go far from their home. So they provide full-time care for their kids, provided that they don't have economic challenges. So we don't need to see or expect fancy nurseries in our rural communities, even in the urban setups. So that has to be taken care into. So I am applying on what I have already responded. I don't think no country do have our community health system we have on the ground. We have a health extension program. We have health post. So that is the best mechanism we have ever in Ethiopian medical history. There was a Almata Declaration in 1978, health for all by year 2000. That couldn't happen. So our government has come up with a new initiative called the Primary Health Care, the Health Extension Program, and that is rolled out to every community in Ethiopia. And we are using the community structure as well, like what Wazir Yayesh has mentioned earlier, and the organizing women in the larger community so that they own the programs, they use the services, at the same time commit resources in building health posters, and even these days they are contributing in kind as well as financially in building maternity waiting homes, ambulances, and other solidarity mechanisms on the ground. So one should not expect other than health posters and as far as infrastructure is concerned. But in terms of community coalition and community engagement, the Health Development Army, Women Development Army, this is a best system to be benchmarked. So that is what I need to respond. In terms of the infant mortality, under 5 mortality, from where we were in 1990 and where we are now, we have achieved the MDGs, but that is not the end target. Under 5 mortality, we were at close to 210 children were dying from every 1,000 live births in 1990. Now the rate is around 64 per 1,000 live births, and the infant mortality is close to 40-something. And the challenge is with the neonatal mortality, which is around 28 per 1,000 live births. That is around 42 or 43% of all under 5 days are in the first months of life. So we need to work aggressively, and we can take lessons of high impact interventions and scaling it up, sustaining it, and improving quality of service deliveries are something that we need to look into. I think I have mentioned about the early childhood care and education, which we have developed, and we have many platforms of interministerial engagements and execution of activities, including nutrition, hygiene and sanitation, reproductive health, and all the others that need ministerial engagements, different ministries. Thank you very much.
Thank you. I want to congratulate all the presenters for excellent presentations, and I think that on the table we discussed key issues in terms of how to complement early child development policies with strategies to decrease infant mortality. I want to say that in general are the same strategies, are very similar, and in health we don't have to wait to have a very low infant mortality to be very strong in terms of early child development policy. I think that you are doing well. Congratulations. Thank you, everybody, for your attention and patience for this. That's all. Thank you.
Actually, well done. Okay, thank you. You said many things we wanted to be